Hey everybody, I hope exam 1 went well and the past material translated to the online environment. And so we're going to start with exam 2 material. So that's going to start on page 70. So don't forget that Spinal is a cumulative class, so everything that we tested on for the first exam is fair game to show up in the following exams. I do try to point out areas that are common for that information to come up, and as we do the exam review, I'll let you know information that classically shows back up on exam 2 in particular for this one. But just a heads up, this book is very repetitive, so it's not very surprising that information is tested twice because it's repeated. So I wouldn't worry too much about that. I'd also like to just quickly hit on the muscles because I know it starts to feel quite overwhelming. You are given lists of muscles. Rest assured, I will point out the important muscles. You will be fine. You do not need to know every single muscle and its origin and insertion throughout the spine. You need to know the important ones. So I will point out the important ones and I'll make sure to highlight them pretty dramatically. So do not fear. So starting on page 7, if you remember from exam 1 reviews, I told you that Mr. Mortar likes AKAs. So we had C1 was the atlas, so you want to know those AKAs. You also want to know C2 is known as the axis as well as the epistrophius. So obviously because epistrophius is this really strange word that apparently I can't say, it's one that comes up pretty regularly on exams. So you're going to want to know how to spell that. You want to know that there's 5 joints on the dens itself. So those numbers didn't show up. Apologize about that. They're all equally number 1. But I often get a lot of people kind of panic about which are the 5 joints on the axis. So I try to just list it straight up so that you can get it squared away in your head. The 5 joints on the axis, on the air quotes body of C2 are going to be the facet for fovea dentis, because remember the fovea dentis is on C1, the transverse atlantal ligament, so that's the seat belt that holds the dens in place, the apical dental ligament, remember that's the one single ligament at the very, very tippy top of the dens, and then you've got 2 alar ligaments. Remember those were like angel's wings, again air quotes, sorry guys. And they're the very strong, slightly inferior and lateral to the articulation of the apical dental ligament. I know sometimes it feels a little confusing still to count ligaments as joints, but they do count as joints. So that's the 5 joints of the axis. Moving on to the bottom of page 71, we talk about different types of dens. So you're going to look at the dens on lateral cervical x-rays and you can determine what type of dens there is. So important to note is that between males and females, a straight dens is the most common by a landslide. You also want to know that lordotic is about 11% and kyphotic dens are about 14%. So kyphotic dens are a little bit more regular or more commonly seen according to Mr. Mortar's book. However, know that for this try. Later you'll learn other information. Okay, important things to know about the descriptions of lordotic versus kyphotic dens. So this is a good thing that you can kind of use your hand, use your own body to try to visualize. You want to relate the facet for fovea dentis to the position of the groove for the transverse atlantal ligament and how the dens is being pulled, forwards or backwards. So that's where a lot of test questions, not a lot, 1 or 2 test questions will come from, and it can be a little bit confusing. So in a lordotic dens, so think of a lordotic curve, like the curve of your cervical spine. Your facet for fovea dentis is going to be pulled above the groove for the transverse atlantal ligament. So if your hand is the dens, kind of fold put your hand in front of your face and fold your fingers back towards your face. That's going to be your lordotic dens. So think about where that facet lies in relation to the groove to the transverse atlantal ligament. And then even more strange of a description is the kyphotic dens. So I would flip your hand around so the dorsal side of your hand is facing you, and then point your fingers away from you. That's going to kind of be the description of a kyphotic dens. Sounds crazy, it's because it is. So in that case, the facet for fovea dentis is located, air quotes, below the position for the groove for transverse atlantal ligament. And then again, those alar and apical ligaments are going to be pulling the lordotic dens backwards and the kyphotic dens forwards. So again, think of where your fingers are in relation to that curved dens. That's pretty much it. Just get your head wrapped around that and you will be good to go. Okay, moving on to the inferior epiphyseal rim of C2. So remember, we are in vertebrae that are abnormal. Obviously, the top is unlike any other cervical. C2 is very unique, but the bottom is pretty normal, if you will. So it's going to be like your typical cervical. You've got your anterior and posterior lips. Remember, your lips lower, and your lateral grooves. You're also going to want to know what that ligamentous anterior boundary of the spinal canal is at this location. So that's a little point on page 72. So the membrana tectoria and the PLL form that anterior boundary, and that's where the transition occurs. So you're going to want to know that, and I have this repeated multiple times through exam 2 material, so hopefully you'll get sick of hearing it. Moving on to those IVF boundaries, so that is under the pedicle part of page 72. So this one's a little bit strange, and I will just note that if you want to if you're a visual person, I would flip to page 82 and just kind of familiarize yourself with this. Typically on exam 2, you're either going to get an upper cervical IVF, not drawing, but question, so where you have to name what surrounds the IVF, or a thoracic, so you're including something rib-like. But in Mr. Mortar's class, the C1 and C2 zygapophysis, obviously this is not a classic zygapophyseal joint like we've been talking about, but if you look on page 82, and I have it on the next page of this, that zygapophysis, or that articulation between C1 and C2, is going to technically form the anterior boundary. That's also true between occiput and C1. So those two upper cervical regions, the IVF boundaries, I have zygapophysis in quotes because no one else would technically call this a zygapophysis, but for your case in this class, this is what it's called. So know that between occiput and C1 and C2, the zygapophysis forms the anterior boundary. And then remember from the IVF drawings in last exam material, every other vertebrae, the zygapophyseal joint is on that posterior side, forming the posterior boundary. So just know that and you'll be good to go. Moving on to the lamina. So here is a muscle you want to know. Know that the obliquus capitis inferior, remember that's some of those suboccipital muscles that we've talked about, that is going to be only attaching to that laminar area of C2. So know that it attaches to the lamina. Another unique thing about the obliquus capitis inferior is that it does not attach to the skull. So remember the rest of our suboccipital muscles, your rectus capitis posterior major, your rectus capitis posterior minor, your obliquus capitis superior, those are all going to have attachments to the skull. And if you remember that both of the obliquus muscles have one unique thing about them, So the obliquus capitis inferior is unique because it lacks an attachment to the skull, and the obliquus capitis superior lacks an attachment to or lacks forming a myodural bridge. And then the rectus capitis posterior minor does not form part of the suboccipital triangle. Remember, the minor is not allowed into the group. So know those unique things. Those muscles come up time and time again, and they're going to be important for life. So that diagram right there is kind of a drawn out version of what is found on page 82. So if you're a visual person, again, those boundaries are important. So Noah. All right, our articular process for C2. I apologize for the way I say process. Sometimes my Canadian shows. So know that the true articular pillar is absent. That is very important. It is not a true articular pillar. And then the orientation of the superior articular facet compared to the inferior articular facet. I have that list for you, so we'll be going through that. But just know this is a unique vertebrae. The top of it is going to be unique to C2. The bottom of it is going to be classic cervical. So the superior articular facet is oriented BUL, so backward, upward, and lateral. And the inferior articular facet is forward, lateral, and downward, like your typical cervical. So remember, typical cervicals are bum fold. This one's bull fold. You also want to know that the superior articular facets are asymmetrical. So remember when we talked about C1, the inferior articular facets of C1 are asymmetrical, so it would make sense that they're going to articulate with some asymmetrical reciprocals, if you will. All right, so similar to C1, there's some numbers that we're going to want to know, particularly the transverse diameter. So that's going to be 57 in males and 50 in females. So those are two important numbers that you need to know, and those are on page 74. Finally, the spinous process. The most important thing you need to know about that is that it is bifid, and that is characteristic of the human species. So a non-bifid C2 probably means you're not human. So moving on to the vertebra prominens. I kind of alluded to this in exam 1 review material. This is a question that will come up on exams in the future, particularly when you're struggling with time and maybe having to rush through reading questions. So you want to know that C7, the AKA for that is the vertebra prominens. And obviously, as a distractor, the vertebral prominence, which is written on the top of this slide, is going to be used as a distractor. So vertebra prominens is a name, and vertebral prominence is an anatomical landmark. So know the difference there. That being said, C7, the vertebra prominens, is most commonly the vertebral prominence. So in men, it's going to be about 86% of the time, women 79%. We weren't classically tested on those numbers. Know that it's most of them, 80 to 85 range. What you do want to know about this is going to be who tends to have, if there's a vertebral prominence at C6, who is more likely to have that? And so women are more likely to have a vertebral prominence at C6 than men, and men are more likely to have a vertebral prominence at T1 than women. So there's that little saying in spinal anatomy that women above men, so a lot of these anatomical variance between females and males is going to occur more superiorly in females and more inferiorly in males. So that's why I have listed women instead of females, because it's the women above men. All right, we're in another transition zone, so know that superiorly you are going to be like a cervical, and inferiorly, remember that's going to be like a thoracic vertebrae. So nothing too crazy going on with C7. You want to know the orientation of the articular facets because that's a pretty heavy hitter on the second exam. So know that the superior articular facet is BUM, like your typical cervical, and inferior is going to be formed, forward, medial, and downward. So that D should be capitalized, like a typical thoracic, which is classic of your transition zones. So the inferior part of that vertebrae looks like a thoracic. As far as the spinous process goes, this is going to be a non-bifid one, which is why it's very easily palpable. And this is a very common test question. Know that all 5 true layers of the back are found at this location, at the spinous process of C7. That is a TQ for sure. Also on page 76, under the transverse process, we'll hit this when we go to the vertebral artery again, but know that the transverse foramen may be absent, singular, or there may be multiple of them, but small. They're quite variable, and that is because the vertebral artery doesn't travel through them. So that's why you'll see so many different types of transverse foramen on C7. Vertebral artery, page 78. This is huge. Obviously, as a chiropractor, you want to know a whole ton about it. You might even get an embryology question on it. So it first appears on day 33, and then it's going to be fully developed on day 54 of gestation. As far as its incidence of injury with manual therapy, it's very, very low. 0.0002% in fact, which there is so much more updated research about that these days, and it's even less associated with chiropractic and a cervical adjustment in particular. It's more the symptomatology that we need to look out for an active dissection. So we talk about this exam in spinal anatomy, and you'll talk about it again in NMS in 5th try. So the vertebral basilar artery insufficiency exam. You're going to hear about this time and time and time again throughout your Palmer education. So this is an exam that was designed to test the patency of the vertebro-basilar junction. So we're testing 2 arteries, the vertebral artery and the basilar artery. If you remember from CNS, the basilar artery is up in the brain, and the vertebral artery is traveling up that cervical spine to supply the brain. So you're going to want to know that it involves rotating and extending the head and neck. So I definitely normally do a little demonstration during our pass hour. So look over your left shoulder and then take try to touch the back of your skull to your right shoulder. So that's going to be rotation and extension on that side. So you're stretching out that left side of your neck. So you want to know that on that ipsilateral, the same side, that's going to be what is compensating technically, but semantics. And that's on that bullet point at the bottom of the vertebral artery question. One of the common questions that gets asked on a test is which 2 arteries which arteries are being tested. And please just know that there's no such thing as a vertebrobasilar artery. So that's a combination of the names vertebral and basilar. So those are the two arteries that are being tested or stressed in this vertebral basilar artery insufficiency exam. I will, however, note that this is no longer recommended or taught in most schools. I believe that Palmer just teaches us this exam in case it shows up on boards, but most other chiropractic schools definitely don't teach or recommend it, and you will be harped on its dangers and lack of specificity and sensitivity, and it is not even taught in medical schools either. So, fun fact. The vertebral artery regions. These, you need to know these so well. There will be at least 2 test questions on this exam, and it'll come back on your next exam. So page 79, everything about page 79 is important. So your V1, V2, V3, and V4, those are the regions of the vertebral artery. So it is helpful to think of the path of blood. So it's coming from your heart, and then traveling up the neck into the brain. So V1 is going to be closest to the heart. A lot of people will, in a testing scenario, mix up V1 and V4 because you typically want to put 1 at the top and 4 at the bottom. But think of the pathway of blood and it will make total sense. So V1 is going from the subclavian artery to C6, because remember that the vertebral artery does not go through that transverse foramen of C7. So the first place it goes into the bony features is C6. V2 is traveling up that cervical spine all the way to C2. V3 is from C2 to the foramen magnum, so entering that cranial vault. And then V4 is from the foramen magnum to the transition of the basilar artery. So that's it, that's all. Just get it straight and you will be good to go. Compensatory loops are also heavily tested, so this is very much worth knowing. Again, thinking of the path of blood, the first is going to be the first loop that the blood hits on its path from the heart to the brain, so it makes sense that it's a little bit lower down. And it's going to occur at C1 to C2. So remember, the range of motion at C1 and C2 is huge because we've got that pivot joint. So at that atlantoaxial interspace, we're going to have the first compensatory loop, and it is very long. It compensates for that rotational movement of its head, and it the loop is about 2 times the second compensatory loop. So it states that the vertebral artery stretches about 50 to 67% of its length there during rotation. So good thing we have that slack built in. The second compensatory loop, that one's found around the lateral mass of C1 going to the occiput. So again, we're going to have some motion there, but we're designed for that. So hooray. Before I get into the thoracics, I just point out the summary of muscle attachments in the cervical spine on page 81. So this is kind of a helpful page when you're talking about all of the muscles. So I have starred in my book, which I would tell you to star in your book, all of the lists that have 4, or sorry, I guess one of them has 6 or fewer muscles. So know less, learn less to know more. Know all of those unique muscles and where their attachments are. So know that the longus colli is going to be attaching to the anterior arch of C1. We're going to find that on vertebral bodies as well. So all the 1, 2, 3, 4, 5, those top 4, if you can call them lists, I would definitely know that. The anterior tubercle versus the costotransverse bar of the TVPs on the right, I would definitely know that. And yeah, I pointed out most of the muscles. So then we've already talked about the IVF. So like I said, typically your IVF question for exam 2 will be either an upper cervical or a thoracic with a rib involved. So I would know page 82. And the ribs are going to be more like the bottom of page 83. So I can definitely make a video to go over that for you if that's helpful. Moving into the thoracics. So we're going typical thoracics first. I have a note to review page 32. So this is where you get a lot of repeat because we already talked about thoracics before. So of course that kind of stuff will come back. Know the different regions. So we've got our T2 to T4 and our T5 to T8. So those are kind of two different groupings of thoracics. So T2 to T4, those are going to be heart-shaped. And then T5 to T8 are more triangular shaped. And that aortic impression is going to be found on the left side of that T5 to T8 grouping. On page 85, we talk about the kyphotic curve. So this is quite important. If you remember, we talked about it pretty extensively regarding the cervical curve, and now we'll talk about it on the thoracic curve. So your thoracic spine has a very typical kyphotic curve, and that is going to be formed by the wedge-shaped vertebral bodies. So they are greater in height posteriorly than they are anteriorly. So they're a little bit wedge-shaped, and that forms the kyphotic curve. The discs are uniform, so they're the same height throughout. If you remember in the cervical curve, the discs were responsible for forming the lordotic curve of the neck. The vertebral bodies were wedged in the wrong direction, so they weren't helpful there. So in the cervicals, it's the intervertebral discs that form the lordotic curve. In the thoracics, it is the vertebral bodies exclusively that form the kyphotic curve. And then we'll talk about the lumbars when we talk about the lumbars, but they're going to be both. Spoiler alert. So we've got our costal demifacets. Remember, on our typical thoracics, we have two different ribs that articulate. So there's going to be 4 costocentral joints. Costo means rib, central means center, which is going to be your vertebral body. We've got 4 of those. Know that your superior demifacet is the larger one. I always think that that's going to be the one supporting the weight of the rib, if you will. So it makes sense that it's larger. It's got a firmer hold on the vertebral body. And that final point about the articular processes. So they're wider on the top. They're a little bit more wedge-shaped. So remember, we put our arms up in the air and keep your elbows where they are and move your hands away from each other. That's the way the articular processes are shaped from T2 to T4, and then they're kind of straight up and down like goalposts, T5 to T8. That costocentral joint, so the joints between the ribs and the vertebral bodies. You're going to want to know all of these things. And it's not that crazy. I know sometimes he powers through and makes it seem a little bit more intense than it is. So as with most synovial joints, all synovial joints, you're going to have your capsular ligament. So your capsular ligament is responsible for stabilizing this joint. Fun fact, and obviously important to you as a chiropractor, is that capsular ligament may extend into the IVF, and it forms the anterior boundary of the IVF. So that pain and discomfort you feel when you have a rib that is not moving well could be because of that capsular ligament, or if you have a broken rib or dislocation. So that costocentral capsular ligament is important, anterior boundary of the IVF. On page 86, you've got your costocentral radiate, aka your stellate ligament. So those two are AKAs. So I would just note that those are going to be, so there's three different parts of them, and you'll see that on the diagram on page 87. So we've got a superior, an inferior, and an intermediate. Your superior radiate costocentral is coming down from the vertebrae above. Your inferior is coming up from the vertebrae for which the rib is named, and then the intermediate is coming directly from that intervertebral disc. So know about those three different parts of the radiator stellate ligament and where they come from. The costocentral intra-articular, or aka interarticular ligament, that one is on the diagram of page 87. You can see it just behind that capsular ligament. So it's coming directly from the intervertebral disc and to the crest of the rib. So there you go. All right, the costotransverse joint. So costo means rib, transverse indicates your transverse process. Remember that those articulations aren't going to be present on every single vertebral level. So know where they are present and the parts of it as they relate to each of the ribs. So the diagram here is on page 90, if that's helpful to you. And I put examples under each of these, which there are also examples in your book, because typically there's a fill-in-the-blank style question on your second exam that asks you to list all of the ligamentous support structures of a particular rib. So for the fourth rib, know that the superior costotransverse ligament is going to reach down from the T3 TBP. So sometimes the superiors and inferiors are a little bit hard to keep straight, but I always think of the superiors reaching down to support the rib below it. The inferior costotransverse ligament is going to connect to the rib at the same level, so inferior, but it reaches kind of straight across. And that's a typo in that example. I apologize. The T3 TBP would go to the third rib. The T4 TBP would go to the fourth rib. And then our lateral costotransverse ligament, that one makes a little bit more sense that it is going to be at that same level. So T3 going to the third rib. Okay, the 5 true layers of the back. This is on page 92. These muscles you need to know. This is a very common fill-in-the-blank question where you have to list the layers, all the muscles in a particular layer. So it's kind of nice that they follow a fun little rule. So layer 1 we call the traps and lats. Obviously don't write lats or traps on your exam, trapezius and latissimus dorsi, but just traps and lats, those are one quick word each. That's going to form the first layer of the true back. Layer 2 is all muscles with 2 words to their name, so rhomboid major, rhomboid minor, and levator scapulae. Layer 3 conveniently all have 3 words in their name, so serratus posterior superior and serratus posterior inferior. And then layer 4 is your erector spinae group, so that's your I love spinal muscles. So iliocostalis, longissimus, and spinalis. If you have to list out all of the 5 true layers of the back, he typically will let you write the erector spinae group, but you should know which muscles are part of that group. Finally, the deepest layer, that layer 5, is the transversospinalis group, so the Mrs. group. That's going to be your multifidus, your rotators, and your semispinalis. So obviously it's important to know which one the spinalis versus the semispinalis belongs to. And that's where the I love spinal mnemonic helps, because spinal is right in that name. You definitely want to know, I'll repeat this again, that every single layer, so a muscle, at least one from every single layer, is found at the C7 spinous. So that's a hot spot for a lot of muscle attachments. And that is a pretty typical question. So there you go. Where will all the layers be found? Spinous of C7. Moving into our atypical thoracics. T1. So that is on page 93. You definitely want to know, obviously rib 1 articulates with T1. There's that full superior costal facet. So it is not a demifacet because it's not articulating with any other vertebrae. Rib 1 only articulates with T1. So it's a full superior costal facet. It has a costocentral joint. However, it has no superior costotransverse ligament. Remember that superior costotransverse ligament reached down from the vertebrae above. So there's no ligament coming down from your C7 vertebrae to support your rib 1. That is important, and that will be a test question, so know that. Rib 2 is going to sit in that inferior costal facet on T1. As far as muscles go, the longus colli that has the vertebral body attachment, you'll want to know that. And that it can be the vertebral prominence. Again, most typically you would see that in males over females. T9, nothing too crazy going on here. You want to know that those costocentral joints move lower. And I don't know why I must have accidentally deleted it, but the inferior costal demifacet may be absent at T9. So we went over that for exam 1 material, but that's the first place that inferior costal demifacet may be absent. Other important things are those muscles that are listed in the questions below T9. So that's on page 97. Those two muscles you for sure need to know. Those are important, guys. So the spinalis is going to be absent at the spinous processes of T9 and T10. Interestingly, they then reconnect down below that. So they're connected at T8 and T11 and T12, but not at T9 and T10. The semispinalis, on the other hand, does not attach to any vertebrae below, or the spinous process of any vertebrae below T6. However, note that it is still present at the transverse process. So if you were asked a multiple choice question that was specific to the spinous, then you know that it isn't attached below T6, but if it's just talking about a vertebrae, it is still present at those TVPs. So there's the answers to those questions. T10, so page 98. Again, those costocentral joints are moving lower and further back. I can definitely send out the diagram that I included on the first exam material to help visualize that. They start to kind of shift back onto the pedicle almost. And the rib 10 costotransverse joint may be absent. The costocentral joint will be absent. Remember, it may or may not be there for T9, but it's definitely not there for T10. So you'll obviously want to just kind of make a mental note if those articulations may be absent. Obviously, the ligaments that are associated with those articulations would also be absent. So on page 99, T10 has a lot of little fun, trivial things that you need to know about it. The para-articular process is going to be most commonly found there. That's awesome to know for your lab exam when you have to identify one. But it's a little bit of trivia here for your lecture exam. You also want to know that it's going to be the last place your levator costorum longus is found. So in spinal lab pass, they often tell you to pronounce the levator I can't even say it correctly now, costorum, costarum, because that is a place that a lot of people get dinged for spelling on their exams. So then you just wind up sounding like you really like rum. levator, costorum longus. So remember, those are going to reach down to 2 levels. So at T10, the levator costorum longus is going to be attaching to the rib 12. So obviously T11, that would be going down to a rib 13. So unless you have lumbar 13 ribs, it's not going to be there. Finally, the dimpling or the depression of the skin. So that's going to be at the spinous process. So the spinous is short and horizontal, and it can lead to this dimpling or depression of the skin. That's a pretty common multiple choice or even fill in the blank style question. So I would know that. All right, these guys, T11 and T12, we'll talk about them again. T11 has an AKA. It's the anticlinal vertebrae. So that is where the spinuses are no longer sloping. You should know that. It's going to be, this is where they start to transition into a more kidney-shaped versus your typical thoracics. So they're starting to look a little bit more lumbar-like. The transition occurs a little bit more slowly. So commonly on a test 2 type multiple choice question, when he's talking about vertebral body features, know that not only lumbars have kidney-shaped vertebral bodies. Like that transition occurs at T11 and T12. So there you go. As I mentioned, the spinalis has returned and the semispinalis is absent because it is absent from the spinous processes below T6. Just double check something. Yeah. Okay, so we'll talk about T12 real quick. So the costocentral joint, remember that's like shifting downwards and further back as you go down the vertebrae. So it's going to be pretty much on the pedicle. The muscles that you want to know about this, the psoas major and minor, those are going to be on the vertebral body. The spinalis is present, the semispinalis is absent, and then but a big fat star by the tubercle homologs. So first of all, you need to absolutely know that there is no transverse process on T12. Just think about setting up for an adjustment. You're not going to be setting up on a transverse process adjustment technically. On T12, there is no transverse process. They've got 3 little bumps, and you want to know what they are associated with. So they're called the tubercles, and they have homologs. So this T12 looks even more lumbar-like. The superior homolog is going to be, it's going to be like a mammillary process. The inferior tubercle is like an accessory process, and the lateral tubercle is like the true transverse process. So know those guys. Which ligament supports rib 12? That one's going to be unique again. So the superior costotransverse ligament is going to be reaching down from T11, and then the lumbocostal ligament from L1 is going to help support it as well. So that's on page 103. That one's a pretty common test question. So this is a rough sketch of the diagram I gave you guys on your exam 1 material, where you can see those costocentral joints kind of going further downward and more posteriorly onto the pedicle. And then at T12, you can see that it's pretty much halfway on that pedicle. Here's another slide just to quickly review those rib ligaments because they're important. So your costocentral capsular, costocentral or stellate, costocentral intraarticular or interarticular, and then your costotransverse. And then you've got a Kahoot. So hopefully that was helpful, and I'll talk to you guys next week.